and coming back to speak with us on your updated presentation, The Doctor-Patient Relationship and Rheumatology Decision Making. Are you thinking what I'm thinking?
Well, I must say it's a pleasure, as always, and an honor that you allow me into your lives and into your homes. While I did not go to the ACR meeting this year for various reasons, I've been going through all of the lupus sessions, and it's mind-blowing what the progress is on every single level. So your future is in very good hands, and hopefully I can give you some facts and ways in which you can interact with your physicians in a more optimal fashion. I'm sure you all do, and I'm happy to answer questions at the end. Medicine is all about you, the patient, not me, the doctor, not this, the hospital, not the system. You deserve the best care, period. And while the power differential seems to be large, it is. You're the powerful one. And you need to appreciate that that is written into the system. And you need to be treated in the most optimal way, in a timely manner, with the highest quality. Next slide, please. So what's a good doctor? You probably have your own thoughts about it. You probably, as a family, has their own thoughts about it. A doctor cares for you and about you. They're empathetic. What does that mean? It's the capacity to recognize and to some extent share the feelings, such as sadness or happiness, that are being experienced by you. The doctor must and should engender trust. So you know that they're going to treat you like they would their own family. They're able to communicate. They speak to you, not at you. They run an effective and efficient office that's up to date technologically, such as electronic medical records and treatment. And they have complete control over their office and the way in which that office responds to you, which should be quickly, appropriately, and professionally. Next slide, please. The doctor works well with the staff. That's the nursing staff, the radiology staff, their secretaries, and is respected by them and respects them in turn. I need to be responsive to all of your needs, however you see them occurring at any given time, day and night. This is a 24/7, 365 relationship. And with new technology, that is a reality that does exist. I'm constantly on my computer all through the day and night, trying to get updates on how my patients are doing. And if they need a response, I try to respond quickly. I need to be responsive to all of your needs, whether they're financial needs, medical needs, emotional needs. I must seem smart, well-trained, and up to date. The way you can tell that I'm up to date is that I'm board certified and recertified. The way you can tell that is you can go on the American Board of Internal Medicine online, abim.org, and see whether I'm recently board certified or recertified in internal medicine and rheumatology. And that's important. For example, I'm in ongoing education. I take tests every 3 months, and I'm graded on those tests to make sure that I'm up to date on what's going on in the world of rheumatology, whether it's related to rheumatoid arthritis or any other area. Next slide. So some of the realities as I perceive them related to the doctor-patient relationship. You should be treated, as I said, just like I would treat my own family. It's a very special relationship. And as with all relationship, needs constant work, honest communication, trust, mutual respect, compromise, understanding, all the things that a regular relationship is about, and then some, because there's this professional issue that needs to be overcome in a way so that you understand. I feel as though I'm sitting at your Thanksgiving table, listening to what's going on in your life, and you feel comfortable with me doing that. Next slide. So how do I see the doctor's responsibilities? Next slide. I need to keep the doors of communication open. And as I said, I have your life on here. With just a tick on my phone, I go to my HSS and the computer, and I can get any information I need, including updated information on your recent messages, your laboratory tests, your recent notes, and pharmacy information. Just like that. I need to respect you. You need to feel respected. I need to offer emotional support when it's necessary. And you need to let me know when it's needed so that I can understand the impact of your illness, its treatment upon you and your family. I need to be an advocate. Recognize that care is a partnership, like with every relationship. I have to assure that the patients are satisfied with their care and develop an office and care environment that's sensitive, supportive, caring, responsive, safe, and private. Now, the MyHSS portal is a private portal. If you send me an email, as some patients do through my regular email, that is not protected. So you need to be sure that you use the MyHSS portal because it is protected. Next slide. I need to keep up to date on medical knowledge and modern care of patients. Again, meaning board certification and continuing medical education. So I may have to take a board examination every 10 years, aside from those examinations I do every 3 months. But I have to be doing continuing medical education. And you can tell at the abim.org website whether I'm involved in continuing medical education as of last week. Meaning I know what's supposed to be going on in rheumatology up to the moment. I need to review your patient medications regularly, educate you about your illness and the medications, potential side effects, costs, route of administration. I need to minimize waiting. I usually see patients on the minute. Now, sometimes, especially now with the traffic in New York, it's very much more complicated. Patients may not be there exactly on time, but whenever you can get there, that's fine. But I need to be there and available to you when you're there. I need to return your calls promptly. Appreciate medical costs, which are quite a significant thing for people, and minimize them. And understand you and your life and your family and the impact of your illness upon you and them. Next slide. I need to be knowledgeable about the current realities of the healthcare system, which can be very complicated, particularly insurance plans. You know, they tend to put things in the bottom of the pile and can't find them, and it's very frustrating if you have to have a medicine sent to you and you can't get to the company. what the realities represent to the patient and specific illness and the financial state. I may give you one medication or a different medication, depending upon your finances and your insurance. And I need to help you navigate through the complexity of a very complex medical system. Next slide. I need to establish a process by which I'm available to respond to problems, for discussions and prescription refills. As it is, I get prompted by your pharmacy like that, and I'm giving you your medication immediately. So it pops up on my screen, it pops up on my computer. I know that a medicine is needed, and I'm able to put it in immediately. And you should then be getting a message from your pharmacy that the medicine is available. Phone messages, office or answering service are time-honored methods, and use them as you wish. The fax, more modern and universally available. Email, now 24/7 via my HSS, which is protected. Cell phones for calls or text messages. Note that regular emails and text messages are not encrypted and protected, but my HSS is. And I, like most of the physicians in an institution like this, are constantly online, seeing whether there are messages that need to be answered. Next slide. My expectations regarding these methods of communication. So what do I expect from you? They should be as short and succinct as possible, as feasible, but whatever you have to say, deliver the information. Use the method that befits the problem. It's your call. If it's an emergency, call 911. If it's not, call my office during the day. If it's not, you can get online with my office and they'll get me through PerfectServe, which is another computer program, and they'll immediately communicate with me. Or you can get my answering service and they will get me, or you can go online to my HSS. You can email me through my HSS anytime you wish, day or night, weekend or not. Next. So what do I see as your responsibilities? You can give me yours whenever you wish. Honestly share your feelings. Respect the doctor, but realize that you don't need to accept poor treatment or slow responses or no responses. Help your doctor be your advocate. Accept your important role in this partnership. And that's what it is. It's a one-on-one, equal partnership. Be knowledgeable about your health and your medications. Keep lists of the medicines and potential side effects. Be an informed consumer of medical care. Next slide. So know your medications, your appropriate doses, reasons for taking them, and possible side effects. Report side effects immediately. Be sure to tell your doctor what medications you're currently taking. Include all prescriptions, over-the-counter medications, health food medicines, or alternative medicines, because they can have an impact upon the way in which your other medicines are working, or they can give you side effects that I need to put in the context of how you're feeling. Tell your doctors which you have medicines that you've stopped. If you don't, the doctor may incorrectly believe that you've been taking it and it's not working. Next slide. Report symptoms accurately and in a timely manner. Give feedback about your care. what I'm doing, my secretary, the hospital, radiology, the lab technician who's drawing your blood. Every level at which you're cared for needs to be watched carefully that they maintain a high quality of care that's respectful to you. Arrive on time as best you can. Expect the same from your doctor. The city has been crazy since September when the Security Council met. It's just been crazy. So I understand that people are coming later because it's so busy in the streets. And when you're giving me messages, be accurate and assertive. I need to know how you're feeling, how long it's been going on, what the symptoms are, how it's impacting you, and how quickly you want me to get back to you. Next slide. I need to know a chronology of your medical history. Always maintain an up-to-date, detailed time chart that includes all pertinent information regarding your health care, beginning with the last time that you felt perfectly well and ending today. And that's how I start the questioning. So when I take a history from you at the beginning, I ask you, when did you last feel perfectly well? You need to go back in time and then start moving forward in time because the chronology is key. It's like Sherlock Holmes. The facts are everything. And the most minimal of facts might be the most important. The trifles that may not seem important may be the way in which I make a diagnosis and decide on therapy. Now, these chronologies can be done by hand, on a legal pad, through a Microsoft Word document, a table, or an Excel spreadsheet. Whichever you feel comfortable with, it's important that when you come into the doctor's office, they have an up-to-date idea of what's been going on. How have you been feeling? Have you had any side effects? Are the medicines working? Is there anything else going on in your life? I'm not your only doctor. I'm not the only person who needs to know about your care. I need to know it all. Next slide. So here's an example of a problem list that I put together, just so you can understand what facts I need. So I have the date of the event, the problem, the doctor that you saw, the tests that they ordered, the medicine that you were given or taken away, the hospital that you were in, the outcome of that visit, and any note that you may want to put together about the visit. So, for example, if on June 19th you went to Dr. Zhu for joint pain, and he or she did a blood test, this complete blood count, a rheumatoid factor, an ANA, and recommended Celebrex for your joint inflammation at a hospital on the west side. And when he gave you that Celebrex, you actually felt better. But you were a bit annoyed about the way in which you were treated by the staff. So these are very powerful pieces of information that you need to be able to pull together. And you may not remember them 6 months down the road. So list them. Here's December 2020. You presented with chest pain when you take a deep breath in to Dr. Garcia. She did an EKG and an angiogram to rule out a heart attack or something. She recommended Norvasc, which is a blood pressure medicine. The hospital was on the east side. And when you left the hospital, you felt much better, but you were disgusted by the dirty emergency room. January 2021, you developed a leg infection, and Dr. Williams did some blood cultures of the leg, of the drainage, and treated you with Ancef and cephalothin, and you got better. And the entire experience was a good one. So you see here, this gives me a global concept of your care since June 2019 to January 2021. And if there are any others that you need to give me, you will. Next slide. Let the doctor know who you are personally. Usually you can see that from an interplay. Are you depressed? Are you anxious? Are the steroids making you anxious? Are the steroids not allowing you to sleep? Communicate about the costs of the medicines and medical care and problems you're having with the insurance. Let your doctor know how you feel and whether you're not taking your medications. Neither am I nor you are mind readers. Communication, as in every personal interaction, is key. Be able to get a feel for the doctor's style and approach to care. You don't have to accept negative behavior. It may be a bad day for me. Hopefully, I will not give that to you. But we all know how to interact with each other. And my job is to make you feel good and to hope that I can make you feel good, both from a medical and an emotional point of view. If you're unhappy with your care, say so. And you have a lot of mechanisms. You can say it to me. You can give me a note to read after you leave. There are ombudsmen at the hospital that you can call. You can go all the way up to the president of the hospital if you're not happy. You don't have to accept bad, insensitive, mean care. Next slide. Communication etiquette. Whichever mode of communication you use, you define the speed with which you need a response and the type of response, what form, what format. Be respectful of the staff's and the doctor's time, but in the end, this is your health and your call. Email should be used via my HSS because it's safe and encrypted. Use it as you wish. But think first about whether the messages after 5 and on the weekends are necessary or can wait until next Monday or the next day. Your call. Be as short and succinct as you can be, because the doctor may have hundreds of emails and will likely respond faster to the shorter ones. We're only human beings. Don't trail multiple emails below the current one, because the doctor will likely photocopy it or copy it for the chart. Whatever you feel you need, call on me, and I should be responsive appropriately. Next slide. Advocate for yourself. Communicate your frustration about the doctor or his or her staff by face-to-face interactions, email, letter, or fax, whichever you choose, whichever you feel most comfortable with. Phone conference. You don't have to be face-to-face. Hospitals have patient advocates to address issues that you feel are or not haven't been appropriately addressed by your doctor. Next slide. Overcoming fear and anxiety of confronting the doctor. Bring a family member or a friend as an ally. It may decrease your angst. Write out your concerns beforehand because your anxiety may make you forget. And everything is important that needs to be delivered. Practice your approach. Since it's all about you, remember, if your doctor does not improve, you can change doctors. It's not the easiest thing from a personal point of view or a medical point of view, but sometimes it's necessary if they and their office have not been responsive to your needs. Next slide. Medicine is all about you, the patient. You deserve the best care, period. And while the power differential may seem large, it is. You ultimately are the powerful one. Even though you may not think that, because the doctors have the information, the hospitals have your records, this is reality. You are the powerful one, and the system is set up surrounding you, not me. Next slide. Let's move on to medical decision making. In the end, like everything in life, comes down to a cost-benefit decision. It's a balance. Costs can be financial costs or side effects. Benefits can be the positives that come from it. The problem is that the physician and the patient may value costs and benefits differently. For example, drugs like hydroxychloroquine or placardin, non-steroidal anti-inflammatory medications, methotrexate, steroids, azathioprine or Imuran, Celcept or mycophenolate mofetil, cyclosporin, tacrolimus, voclosporin, intravenous gamma globulin, Safnello, Benlysta, cyclophosphamide, rituximab. I've listed all the medicines that we use. And to me, these drugs, while having side effects, can be monitored well to assure effectiveness and avoid side effects. To the patient who Googles it or speaks to their friend, it may seem like, are you serious? Why would I give you this toxic drug? Next slide. I just push the slide again so you can see the arrow. So this is the rheumatologist's perspective on the available medications for patients with SLE. So this arrow is pointing in this direction. And this direction is increasing power against inflammation and increasing potential side effects. This includes all the medicines that I've mentioned before. So the medicines that have the lower potential of side effects, antimalarial drugs, low-dose steroids in short courses, topical steroids, non-steroidal anti-inflammatory medications like ibuprofen or Aleve. The next highest dose with regard to potential side effects are methotrexate, mycophenolate mofetil or Celcept, mild to high doses of steroids, leflunomide or Arava, Imuran or azathioprine, or voclosporin. It's a new medicine that's very good for kidney inflammation. The highest potential side effect profile or cyclophosphamide or cytoxan, intravenous gamma globulin, rituximab, Safnello, or Benlysta. These are two very impressive biologic therapies that have come online along with voclosporin over the past few years and have made a huge difference in our care. So the way I look at it is, as the amount of inflammation increases, I may have to up the ante from these drugs, which may not have worked initially, to these drugs which may be necessary. And my choice is my balance for you on your behalf, trying to put together what I think the best outcome is with regard to improving your life and limiting the side effects. Next slide. So here's my thought process. This patient has a problem that needs to be treated, such as weakness, muscle pain, skin rash, fever, arthritis, shortness of breath. I need to make sure that the treatment chosen befits the intensity and the severity of the problem. I'm going to say this in a strange way. Does the punishment fit the crime? What that means is, does the toxicity of the side effects meet the problem that I'm trying to treat? With joint inflammation, fatigue, and skin rash, I'll try to use kinder, gentler medicines, such as non-steroidal anti-inflammatory medications, topical steroids, antimalarial drugs, sometimes oral steroids in short courses. For more significant inflammations, such as lung inflammation or chest pain, kidney problems or neurologic problems, I will likely choose medicines along the end of that arrow, that red arrow, because the problem's more significant. And experience has shown that hitting it harder and earlier assures the best outcome. So I will use oral or IV steroids or immunosuppressive drugs. You have to trust me to make that right balance. But I have to explain it to you and give you reading material. And you can go online and find out whether you actually believe what I say is true. But I will always try to err on the side of your safety and your best outcome. Next slide. So the good, the bad, and the ugly. So what's the worst bad? The illness? Let me distinguish between illness and disease. Disease is a pathological state like lupus that can cause arthritis, kidney problems, etc. The illness is the person in which the disease exists and their emotional and personal response to having that problem. So what's the worst bad? The illness, the medication that I'm recommending, doing nothing and just letting nature take its course. Given my knowledge about both your illness and the medication, I can come to a decision easily, but you may not want to. You have complete sway over your destiny. And while I may think I've given you a cogent argument for a certain medicine, you just may not cotton to it. You just may not think it's at all reasonable, or you may have heard terrible things about it and just refuse. It's your destiny. It's your body. You have full control over it. I then have to either try to explain it to you, give you reading material about it, or find an alternative medicine that I think will be reasonably similar in outcome to what I've offered you before. Next slide. So why might a physician want to use a specific drug? Well, it works quickly and effectively, and its cost-benefit balance is quite acceptable. Steroids, for example, double-edged sword. Deal with the devil. You all know this. So if somebody's very ill with a lot of inflammation, I may want to give them a short course of steroids in a moderate dose to get them back on their feet, and then get the dose down, but allow the new medicine to take its hold on a person who is not having a lot of inflammation. And steroids, as you probably know, are sometimes like giving spinach to Popeye. Boom, you're feeling better, but at a cost. And you all know may know the cost. And I try to limit that as much as possible. But sometimes it's a necessary part of the regimen. I may want to use a drug because of randomized controlled trials in the same population of people like you are at the time of the problem. And it's shown safety and effectiveness. I'm now going online to the meeting in San Diego and learning new information. And I will want to bring that to you in an updated fashion. Now, there may have been long-term surveillance studies done during the Food and Drug Administration have shown the results are the same when given to patients outside the studies. In a study, you have certain patient populations that are chosen. They may not exactly represent you, but I have to put it into the right context. Now, why might I use a drug? The milder or current medications that you're on is just not modifying your disease and is not working. And I believe that we have to make a change to get you feeling better. Next slide. Why might you not want a medicine? The patient doesn't like any medication because in their and their family's experience, the cure is always worse than the disease. And I understand that. Medicines do have their problems. You might fear the medication more than the illness, or you've had experience with it, and it's the last thing in the world you want to re-experience. You heard from other patients that the drug causes all sorts of problems. You heard from an ad on TV about the drug that scared the hell out of you, including at the end that rapid machine gun statements about infections, et cetera, including toxicities that scare you. Or the drug hasn't been out that long. You've looked it up on Google. And we may not know its true long-term side effects in the real world. I and most of the people in an institution like this would try to really understand the drug, make sure it's effective, and has a good enough track record that it's the right thing for you at that time. The right drug, in the right person, at the right time. I'm always thinking of that. Next slide. So how should the doctor and the patient come to a final decision? Each should give their perspective on the drug and the illness, what their concerns are, and what information they may need to make the decision. The physician should give the patient reading material and the patient can do their own homework online. With permission, the physician should give out some of their patients' names and numbers who have been on the same medication, my patients, and they've made the same decisions that I want you to make. This can be helpful in you getting over the barriers and fears in people who've already made that decision. Better yet, referrals to peer counselors, such as Lupus Line at HSS, may be quite useful. A second opinion may be helpful. And either I would be happy to give you the name of a second opinion, either at my institution or another institution. The SLE Foundation may, or patients may. Whatever you choose is fine with me. But time is of the essence here, and we need to move along. But ultimately, you have to make the decision. Next slide. Coordination of care is key. Remember, you're two people. You're a person with SLE and a normal person. You can get any medical problem each of those patients can get. It's up to your rheumatologist and your primary care and other doctors to sort this out. You may have back pain because you fell, but back pain is not lupus. You may have fever, but that may be due to lupus, or it could be due to COVID or a viral infection. That's up to me and your other doctors to decide what the origin of the problem is. Or you can have overlapping problems. An infection like COVID or a virus can trigger lupus, and you can have both. Close communication and collaboration between your rheumatologist and other physicians is vitally important in assuring your best overall outcome. Make sure that each doctor knows who the other are. I want to know their names, their numbers, faxes, cell phone numbers, email addresses if possible, so I can communicate with them. So I'm not making decisions blindly, but I'm discussing it with the other doctors who have a different perspective about your care and your health. Next slide. Well, that's it for today. I hope you've enjoyed this. I'm happy to answer any questions that you might have.